Welcome to one of my new favorite things at Survivor Corps, because we understand that you can't always get to the experts. So we are here to bring the experts to you, and there's no other expert like this one for our first repeat performance, but with all brand new information. We have Dr. Putrino from Mount Sinai's post-COVID care unit, and I don't want to spend too much time talking. I know that's hard for me, but you guys sent in so many questions. I want to use this time as efficiently as possible so we can get to as many of them as possible. But first, Dr. Putrino, welcome back to your second round of Survivor Corps webinars. We're thrilled to have you. Can you just tell us a little bit about yourself and about the program at Mount Sinai, and just sort of generally what you've been seeing, people suffering with COVID-19 residual symptoms, these long haulers that this group is quite well aware of?
Yeah, absolutely. So my name's David Putrino. I am the Director of Rehab Innovation for the Mount Sinai Health System, which basically means that pre-COVID, what I got to do was run around and find the coolest technologies out there to potentially help patients. And during and post the first surge of COVID in New York City, we brought a lot of those technologies to bear to really do what we could to help the struggle to maintain good quality healthcare to everyone who was exhibiting symptoms and required care. So then after Mount Sinai started to slowly recover from the brunt of the first surge when things got really bad, we established a Center for Post-COVID Care. And that is directed by a really phenomenal doctor by the name of Zizhan Chen. And he has been working tirelessly to build this center out, which is the first of its kind, to make sure that what we're trying to do is be as inclusive as possible, as scientifically rigorous as possible, and really start to understand the sorts of care that individuals need post-COVID. I think also, just to sort of get it out there from the beginning, the Center for Post-COVID Care, for a number of different reasons that are related to compliance and that are related to making sure that that we align with other centers that are starting to emerge that are trying to address similar issues. The center officially can only take individuals who are either PCR positive or antibody positive. But what we have been doing in close collaboration with Dr. Chen is making sure that anyone who is PCR negative, or never had a positive PCR test, I should say, and antibody negative, can still receive care for long haul symptoms through our center and our collaboration. And so that's
a change since we spoke. That's fantastic, because I know that many people have found themselves in.
And one of the things that I do also want to stress is that our admin process in a rapidly built up program is by no means perfect. So if somebody says, oh, Mount Sinai, the Center for Post-COVID Care doesn't see people who weren't PCR positive or antibody positive, the best thing to do is contact myself or one of my team at Abilities Research Center at mountsinai.org, and we can make sure that you get seen, so long as you are within the state of New York.
You just had thousands of people writing down that address furiously.
And we're doing our best to see everybody and make sure that no one is falling through the cracks right now.
Thank you. That is wonderful to hear, because I know that has been a big issue for so many survivors, and so that is terrific. I'm going to just jump into questions right away because we have so many, and I could go on all day. I'm going to start with one that feels a little bit personal. So I actually saw you do an interview with the Long Haul Fighters group. We love to you know collaborate with as many of the other groups as possible. And you were asked about viral reactivation, and some people seemed kind of alarmed at the idea. And, how can there be a reactivation if there's no active infection weeks or months after the initial infection? Does that mean that you're still contagious? Is it a reinfection or a flare? Can you tell? So, just from a personal note, I have to say that I really was better for like 6 weeks. I was walking 10 miles a day. And in the last few weeks, the GI issues are back. The insomnia is back. I've lost all the weight that I gained. I can hardly walk around the block. So, if I were to go to my GP, they would think I was crazy because I was fine for 6 weeks. What's going on?
So, I'll start by saying this is complicated, and I'll also start by saying I heard that use of the word reactivation worried a lot of people. So I want to be really clear that people were asking about this exact issue. I was fine for a while, and then symptoms returned. Now, I think that the first thing we need to work on, and this is important, and I know that I say this with the understanding that not everyone is having this privilege, but the importance of working with a good PCP on this is super important. The first thing to establish is, are you experiencing more long haul style symptoms, erratic heart rate, palpitations, exercise intolerance, shortness of breath, extreme fatigue, GI issues?
Gas.
Or are you experiencing COVID symptoms, which are, cold and flu symptoms, anosmia, still shortness of breath, a cough? There are some overlap of the symptoms, but does it feel more like a flu, or does it feel more like this new thing, this long haul COVID thing? Because the way that we're viewing the long haul symptoms as sort of an issue with the autonomic nervous system, we've said it a few times. We call it dysautonomia-like because we're not comfortable diagnosing.
I'm sorry. Can you explain the word dysautonomia? I'm not familiar with it. There might be others who aren't also.
Absolutely, and I want to. So let's start with these long haul symptoms, and you're going to read a lot of words around this long haul syndrome. There are some people who are coming out and saying it's dysautonomia. There are other people coming out and saying ME or chronic fatigue syndrome. There are other people coming out and saying mast cell activation syndrome. There are other people throwing out many other types of autoimmune syndromes and saying it looks most like this. Our position with the center and with the physicians that we're working with to manage our long haul patients is that we don't really want to name it right now because, effectively, all of these conditions are syndromes, which mean there's no blood test that tells you that you have them. The physician will count the different symptoms you're having, and if you check off, 7 of the 9 boxes, you have this syndrome. That's what a syndrome is. It's a collection of symptoms. Right. And so, to be perfectly frank with you, if I were to pull out a form and I have the symptom categorizations for mast cell activation syndrome, ME, and dysautonomia, I could, in most long haulers, I could check off all of them and say you've got all 3. And so for that reason, we're really not, falling over ourselves to give a definitive diagnosis on this. We are being much more patient-centric and symptom-centric. So when people come in and say, these are my constellation of symptoms, we work to address those. If they come in with a different constellation of symptoms, work to address those. The reason that we say dysautonomia a lot is, to be honest, in our camp, to be perfectly transparent, dysautonomia seems to be winning in terms of it looks most like that to us. But I also don't want to cause any distress or alarm in when you might go to another doctor.
Can you define dysautonomia?
Yes. So dysautonomia is we have an autonomic nervous system. So this is the portion of your nervous system that controls all of the things that you don't need to actively think about controlling. Your breathing rate, your heart rate, swallowing, different glands secreting different hormones. These are things that we don't need to think about, and they just happen. Now, in many cases, following a physiological shock, the autonomic nervous system can get knocked out of balance. And now this can happen for a number of reasons. People get dysautonomia because of a concussion. People get dysautonomia from cancer. They get dysautonomia from viruses. They get dysautonomia from many different situations.
Right. And we saw this after the 1918 Spanish flu. We saw this after Ebola. We've seen this after other viruses. But is this different than that? And how long did it take in those situations to resolve? And is that any indication how long this might take to resolve?
Yeah. So I would say that so far, in terms of the reading that we've done, the severity here is the severity and even the incidence is no different from what we've seen previously. It's a fair chunk of people. Like I'm still being very wide with my error bars and saying 5 to 15% of individuals, but it's a fair proportion.
The CDC said 1/3, and the CDC tends to be conservative in their numbers.
Right. So, I'm using my numbers, and but I mean, again, I'm happy to acquiesce to the CDC because they seem to know what they're talking about from time to time. But yeah, but from whatever we're seeing, it's relatively common, and it is fitting this profile of this a post-viral syndrome that seems to indicate that the autonomic nervous system is out of balance. And the reason that, as I was describing, the autonomic nervous system does so much that the reason when it's out of balance that your symptoms can be so variable and so, seemingly random, is that this is when you start to realize, how complicated the body is, so the idea that you go outside, you get a little bit of sun, and all of a sudden getting a little bit of sun causes vasodilation, which increases your heart rate, which then triggers the autonomic nervous system. And then all of a sudden you're feeling dizzy, like you're about to faint, and you need to run inside, and that's you for the rest of the day. These are the sorts of things that are very, very common and familiar to individuals with dysautonomia. And we're seeing a very common to individuals who are COVID long haulers.
So does that mean that we can take out the term reinfection? When I asked Dr. Joyner of the Mayo Clinic last week, I asked him directly, has there been a documented case of reinfection? And he said, no. I'm going to ask you the same thing. Has there been a documented case of reinfection?
There has not been a well quantified case of reinfection. So what we have seen, we have seen individuals who tested positive, tested negative, and then had symptoms again and tested positive again. Now, a reasonable theory there is that they may have been reinfected. However, an equally reasonable theory is they tested positive because they had COVID. They tested negative because they still had COVID, but they received a false negative test. And then, you know, as we all know, with, you know, experience of getting other viruses like the flu, sometimes in some cases, if you're having a particularly hard time getting over a virus, you can get pretty good. You can be feeling okay. And then you'll do something that maybe was overstressing your physiology, like you had a late night, or you did, you know, or you had a couple of drinks, or you did something, and your body became vulnerable again, and the virus sort of surged again, and you feel sick all over again. And so in those cases, I mean, I think that calling that reactivation is probably a big mistake. I think, you know, again, what is most likely is that you weren't fully over the virus, and then you, you know, with a weakened immune system, something happened that made you vulnerable again, and the virus, you know, that wasn't gone yet, came back. And that tends to be the most likely scenario and the most logical response to why these things are happening.
Thank you. That actually clears up a lot and can end many of the threads on our page. So, you know, this sort of ties in a little bit, but it gets into some of the symptoms that people are experiencing. Someone wrote in, I'm still experiencing long haul term symptoms such as joint pain, GI symptoms, headache, fatigue, and ringing in the ears. I had antibodies in May. I'm going back to work as a school teacher in September and concerned about getting the virus again. How will I be able to differentiate between long-term symptoms and reinfection? And do you have any safety recommendations for me at work?
I mean, to be clear, I'm, you know, not a big fan of reopening the schools, to be honest. So I'll say that. I mean, my safety recommendations would be you know, fight to keep the schools closed and keep distance learning going. However, that's, you know, that may be a pipe dream. That's certainly outside of my wheelhouse, but
or unless there were perhaps rapid testing available at home, rapid testing before each person walked in the building.
Yeah, you know, that is the main thing that I always, you know, again, to talk pre-COVID, one of the centers that I run is a human performance center where we work with high performance athletes. And so during COVID, much of my workload for that center has been sitting on advisory boards for NBA teams, NFL teams, Major League Baseball teams to sort of discuss return to play. And we know
how that's gone.
In the absence of, you know, my initial recommendation is, are you crazy? Don't return to play. You know, America can go without sport for a little while. My second response is, you know, okay, rapid and repeated testing. And the one thing that I love working in high performance sports, the one reason I love working in high performance sports more than most is often when you have contentious issues like this, you really get to the truth of it, because these people don't care about politics. They care about, like, okay, there's like $90 million at stake here if 3 of our people get sick. So what are we going to do? And what the sporting teams that I'm working with have come up with categorically is no sports star gets in the room with other sports stars unless they have somewhere in the neighborhood of 4 to 6 negative tests back to back to back. So
okay, so but this teacher is not going to have that.
So
this teacher to protect him or herself.
In the absence of that, you know, masks, good hygiene, and being obsessive face shields, absolutely. Being obsessive about hygiene, being really sort of obviously in a way that is gamified and enjoyable for the kids, to not completely scar them and terrify them, but like educating the kids about hygiene, making sure that, you know, we've got a fun protocol for them to go through every time they get back in the classroom. These things really, really work. You know, I am incredibly fortunate that I've not contracted COVID, but I was on the front lines for 10 weeks during the worst surge in New York, and going to the hospital 6 to 7 days a week.
Right. Unfortunately, our teachers won't have PPE
Exactly.
of any kind.
Exactly.
So,
but
I just want, I don't want to interrupt you, but we just have so many questions
go ahead.
to get to. What new developments are you seeing in regards to long haulers, and what treatments are being used from like a holistic perspective? And then we can go maybe more symptom by symptom of ways of treatment. And one of the questions that I'm very curious about is, I've heard that there is some research being done into the use of convalescent plasma for long haulers. So if you can discuss all of that.
Sure. So far, the major success that we have been having in addressing long haul symptoms has been in working to recondition the autonomic nervous system. So there is a lot of literature about this, but what we're seeing as we've started to dig into 100 or so long haulers is that most long haulers are so deconditioned that starting off on any of these exercise protocols just cold turkey would be a complete disaster, because they actually start at a level that is too challenging for many long haulers to manage. So what we've actually moved on to is working with certified breathwork coaches to build out breathwork protocols that will initially challenge the nervous system, get your heart rate up a little bit just from breathing, but you're not actually doing any exercise. And that is how
Where members access those videos, those of us, you know, the 99.999% of us who will not be able to get into your center, how can they access videos like that so that they can do it at home?
So I believe that I've connected you guys with one of the coaches that we're working with.
So we'll make sure it gets out then. We'll make sure it gets out. Okay. Yeah. So go on. Sorry.
And hopefully he'll take you guys through a full session, because he's actually developing a custom breathwork protocol for long haulers.
Terrific. I think that's actually one of our webinars coming up.
Yeah.
So, okay, so I'm sorry, go on.
So in addition to that, we have developed a sort of a holistic program focused on nutrition. So we've got a really great nutritionist working with us who is developing some general guidelines, which I will share with you guys. We're just turning it into a pretty page right now so that it looks somewhat presentable, but she's been working one-on-one with multiple long haulers to get a sense of their symptoms and what aggravates and what eases certain things. So based on that, and based on her existing vast knowledge on nutrition science, she's building out some nutritional guidelines.
So what'd she say?
Sorry?
What did she say?
So, I mean, largely speaking, it is focused on a few behavioral changes around avoiding pro-inflammation foods. And, you know, there's a list of pro-inflammatory foods, and she gives some guidelines on how best to integrate that into your existing diet.
Like a Whole30 type of diet where you take out all inflammatory, all fake sort of food,
that's
no sugar.
Yes, that's definitely part of it. And I'm trying to be really careful with my words because Adina, the nutritionist, would slap me if I said Whole30 because she doesn't really ascribe to specific diets. But yes, um, you know,
Ish.
avoiding things that cause inflammation, of which there are many foods, and she's pulling together a resource list of how to identify foods that cause inflammation. Focusing on intuitive eating principles, which sort of take you through sort of a checklist, an internal checklist as you eat to identify things that are setting off your symptoms, because these can be slightly different for everybody based on different food tolerances and different food sensitivities, because any food.
Yeah, we did get a lot of messages about newly onset food allergies.
Yeah. Well, I mean, I think what's going on there is when your immune system is ramped up, and you had a mild food sensitivity before, any food becomes an inflammatory food in this particular state, because now all of a sudden the whole system is very, very sensitive. So it's going to reject a lot of foods that were previously fine. And so Adina's really good at sort of training people to listen to their body, understand what goes against them, what works for them. Because in many cases there's no sort of blanket approach to this.
I want to get back to what are the other sort of, I'd like is convalescent plasma being thought of as a treatment, or are there other ideas of holistic treatments? But beyond those sort of like diet and exercise type of things, what do you do if you're a long hauler, you don't have access to a center like yours, and you are going to your regular doctor? Do you order blood work? What do you ask for? How do you advocate for yourself? So first, if you could answer the convalescent plasma or any other treatment question, and then if we could sort of move into how does one advocate for themselves, and what sort of blood work should people be asking for? What kind of tests should people be asking for now that we're especially seeing symptom effects like on the heart, where they're really even from asymptomatic people. It's concerning, especially even for our children who have had COVID.
Mm-hmm. So in terms of novel treatments, we are watching the convalescent plasma and the synthetic antibody experiments. We've isolated we've identified a couple of groups that are starting to look into this. None of them have actually started active clinical trials just yet, but that is something that we are certainly keeping an eye on. And if it becomes evident that it's having an effect, we will definitely start offering it. The other thing that we're looking
at, do you know where that research is being done?
Yes, so there's a group in Westchester County that we've identified, and there's a group at Yale, I believe, that has been doing the convalescent plasma work. The other thing that we're actually looking into starting ourselves, and I saw it in a question elsewhere, is IVIG infusion.
Yes, we've had questions about that.
This is.
I don't know what that is.
So
can you?
Yeah. I mean, it's an immune compound. IVIG is what is known as an immunoglobulin, and what many people with dysautonomia specifically in the past have reported is that an IVIG infusion can really help their symptoms recover. And in many cases, people will say, "Hey, this has been, quite transformative to what's going on." I think the data are somewhat murky, but it seems to be more geared toward people who are getting dysautonomia as a result of a strong immune reaction. And certainly currently that is our existing theory. So one of the things that we're doing is we are starting a collaboration with the immunology group at Yale, and we're going to design a protocol where everyone who gets a specific series of tests with the team at Yale will then go through an IVIG infusion, and we'll look at what happens to their test results post-infusion.
I volunteer.
Yeah, okay. I'll add you onto the list.
I'll be first.
And this is brand new, by the way. So we actually just had the first conversation here this week about this sort of thing. But that's something that we're looking into on the novel therapy side of things. But right now, we're getting steady results from the behavioral interventions that we're applying. We've had a couple of long haulers. I don't want to create false hope, but we've had a couple of long haulers really transform over a few weeks. Now, I want to point out that's not the norm. We expect this to be a 3 to 6 month process to recover once you get into a steady staged intervention program. But we're seeing some very strong responders in our early group, but for the most part, people are just having steady progress.
Any suggestions for, it happens to not be one of the problems I had, but so many people have lost their sense of taste and smell, and it really psychologically seems to be impacting people. I mean, just as every single symptom seems to psychologically impact people. Are there any particular pieces of advice that you can give to people on how they can practically help themselves regain those senses?
So the loss of sense of smell has, the long-term loss of sense of smell has been a little bit baffling for most of the doctors. No one really knows why it's happening, but it's certainly happening. The clinical trials that I'm aware of right now to help people regain sense of smell, which is really about promoting recovery of the peripheral nerves, the small nerves that allow you to smell things. They're using fish oil, daily doses of fish oil, because this has worked previously in the past where inflammation has caused a loss of sense of smell. And really the idea is to accelerate the process. Similarly, and I know many people are doing this already, but there really is good evidence for it, lots of sensory integration. So there are groups online.
I've heard if you eat things that have more texture, that can help. Is there any truth to that?
I mean, yes and no. It's really about, it's about giving your sense of smell and your sense of taste as diverse an experience as possible. So it's eating things with texture, it's eating things without much texture, it's eating things that are really sweet and eating things that are really savory and eating things that are sour, and really making sure that you're giving, really giving the neurological system responsible as many strong cues in as many diverse directions as possible to promote recovery.
That's super interesting and very, very helpful. So now moving back to sort of the next question was, let's say I had COVID, my whole family had COVID, my kids had it. Actually, my 11-year-old is having some, minor, not anything crazy, but he has some long haul symptoms and he's 6 months in. What do I do? What if I don't have access to a center like yours? And what kind of tests do I ask for? How do I follow up on my care? My GP doesn't know anything about COVID.
Yeah. So this is an issue that we're having a lot of. Some of the best ways that we're finding we can bring the symptoms out are by, so this is a tough question because I don't want to steer anyone wrong. Some of the best ways that we're having to bring symptoms out in a way that a doctor can measure are looking at what happens to your heart rate and your blood pressure when you transition from lying to sitting and sitting to standing, because they can see that some people's heart rate will jack up when that happens. Now, the reason I say this with a little bit of caution is that that's not everybody. And so I certainly don't want to have a situation where I say, you know, go to your doctor and tell them to do that, and you go in full of confidence, and then your heart rate does nothing, and you know, that could be an issue as well. But right now, that is the most quantitative symptom that we have in terms of, in most people, that is happening. The other thing that
the GI, how about the GI issues? That it's pervasive.
Certainly, GI is, you know, is something that is happening, but again, it's hard as a doctor to quantify that. They can't measure that. They can hear your reporting of it, and then they can either.
So there's no test you can go for. There's no test that you can request. Is it possible that the virus is, you know, we're only swabbing the nose? Could it still be living somewhere in your gut?
That is a question. We're looking into a question similar to that, but not quite the same as that. I don't think, for the most part, in people with long haul symptoms, and I'm sorry, I just had to change my camera a little bit. I do not think that for the most part, we are experiencing, we're seeing people experiencing the virus hiding in different organs. I've heard a lot of questions and a lot of concern around that. I've particularly heard people citing post-mortem studies, and the thing I want to say about that is the post-mortem studies were done on people who died during active COVID infection. So it is expected that virus would be found all over the body and in organs. However, once you're over the virus and you're developing long haul symptoms, we do think that it is more related to dysregulation of the autonomic nervous system or some similar process. And so we think that the GI symptoms are, one of the things that we're looking into right now is, you know, what the gut biome is looking like. Can we do some gut mapping to try and understand what this virus has done? You know, what is the aftermath of the virus in the large intestine? And so that's something that we are actively looking into. And we don't think it's related to the virus still being in the gut. These are all theories, by the way. You know, it's not a hill that I'm willing to die on. You know, we're just learning every day.
But nobody's out there doing stool studies, but no one is out there doing stool studies or anything like that. They're all still nasal swabs, correct?
There are actually COVID stool tests that can be done. They're just not. Pardon me?
Have they shown anything different than the traditional nasal swab?
They have shown good correlation with the nasal swabs. Meaning that, yeah, if you see it on a swab, a nasal swab, you're seeing it in a stool sample.
So we have a lot of questions about specific symptoms. And obviously you're not going to be able to go through all of them. We'll go through a few, but before we get to that, one of the most actively debated things on Survivor Core are vitamins. Going back to day one of Survivor Core on March 24th, I think the first question had something to do with elderberry syrup. So can you give us some definitive answers on, one, are there supplements and vitamins that you can take that build your immunity that might keep you from that might give you some protection against COVID? And once you have COVID, are there any supplements or vitamins that you would recommend to take as a long hauler or with an active case of COVID, sort of all along the spectrum? Any of it? None of it?
You know, first of all, disclaimer, check with your doctor, et cetera, et cetera. I'm not here in the habit of telling anybody to take anything because I haven't personally assessed thousands of people listening.
But with full caveat. With full caveat.
Yeah. In terms of the research around these things, no one has definitively shown any supplements to improve immunity to or some sort of resistance to COVID. And many things have been tried, but it's just nothing out there is really showing any sort of efficacy in that regard. And you can go into rabbit holes, like there's like oregano oil and vitamin C and mega doses of vitamin C and vitamin B, and nope. Similarly, for duration of symptoms, this is not to say that supplementation may not help duration of symptoms, but the data are so noisy. And, to be fair, this is the issue with many supplementation studies. It's very hard to know what's going on. With long haul symptoms, there are a couple of things that we are actively investigating. We're working with a functional medicine doctor who, of course, would be horrified by me saying anything specific, because her entire, scope of practice is everyone's a little different. So we need to evaluate everybody to look at, your ability to absorb these vitamins and minerals. And so
unfortunately, you're talking to an audience, most of whom don't have access to that sort of individual care.
Understood.
So while that might be ideal, any advice that you can give specifically to people in terms of the most common complaints that they're having, which are neuropathy and shortness of breath and joint inflammation and this sort of myriad of, we know the hair loss has gotten a lot of media attention. It's the one thing we know will come back. That one we got, but everything else, I realize you can't give medical advice to an audience on the internet, but at least how can people advocate for themselves with their own doctors? How can, what do they ask for? How can they petition in the most effective way to get centers like these? Looking at the numbers, it's obvious that we're going, yours was the first, but it will be likely and hopefully the first of thousands, because when we look at the numbers of infections in the United States, we're looking at conservatively already at over 1 million long haulers.
Yeah. So, I've been constantly incredibly impressed by the sort of size and the power of the long hauler community and the advocacy groups. And I think, yep, absolutely. And I think that one of the most important things, one of the most important uses of that power has to be identifying large medical centers that might be willing to listen. Sure, I have to believe that someone within a long hauler community in each state has some sort of connection to somebody who knows these things and who will at least listen, and then getting them connected to us.
On a local basis, identify the hospital that you think is most likely and has the resources to do so, and petition that it hospital by hospital. You think the best,
and connect them directly to us. We are currently training a hospital system in DC. We're currently training a VA system in Arizona. We're currently training a hospital system in New Jersey. We want all of this information to be shared because, our poor doctors are getting, absolutely overwhelmed with the demand. And, this is about helping the community. We are willing to do anything that we need to. We're willing to, I've got one of my physical therapists, literally her whole job right now is running around New York, virtually.
Of course, as everything is.
To train other physical therapists how to run the protocols that we're prescribing so that we can refer out to more and more centers. We're really trying to make sure that everyone is empowered with this knowledge so that we can help as many people as possible.
In the meantime, is there any plan to create a telemedicine version so that people who are, they could be, as this virus is, tearing through rural communities who were medically underserved to begin with, and not to mention just low-income areas throughout the country who have been medically underserved. Are there plans to look at this with sort of that kind of equity in mind and try to offer a telemedicine option for those people who maybe, or for those who are out of reach, or focusing specifically on communities that were hard hit by minority communities? Is that, I'm hoping, is part of the strategy?
So this is, as you might imagine, this is challenging because this is bigger than us. We're bound by federal government law about where we're allowed to practice medicine and where we're not. One of the things that we are trying to do is to educate local doctors to prescribe things like remote patient monitoring, and then link the patient to us, because if we have a physical therapist doing the remote patient monitoring out of state for the doctor who is in state, and the physical therapist is very well versed on how to treat COVID long haulers, then we can sort of effectively shadow manage the case out of state.
I love that.
While we're trying to sort of,
and you're empowering the local medical the local clinicians to be able to then, I assume that there's a waterfall effect, a cascading effect of education that would ensue, or hopefully.
Well, that's what we would hope. And as you can imagine, I mean, our biggest challenge has been to get physicians to refer to us or to even speak to us. And I'm afraid I don't have a good solution for that, other than, and I understand that this is privileged advice again if you're like in a medically underserved community, but if you're getting the vibe that the doctor is not listening to you, find a new doctor, but if download our white paper from survivorcore.com and print it out, bring it with you to the doctor. And when you are describing your symptoms, you can look at the 98 listed, and if all your symptoms are in the top 10, it might be that doctor will take you more seriously. Exactly. And, and again, we're just trying to advocate, and really get the voice out there that a major medical center in New York is taking this seriously and managing the care of many patients, both PCR positive, PCR negative, antibody positive, antibody negative, with these symptoms.
Which leads me to my next question. So many of the questions were about being antibody positive, antibody negative, what it all meant in terms of long haulers, because the tests seem to be all over the place. I will tell you, I have had 12 antibody tests. 10 have been positive, 2 have been negative. Of those 2, one was an off-label Chinese home kit that someone left in my mailbox, not particularly surprising. The other one was Abbott. So with that in mind, someone wrote in late March, I went semi-comatose for about 4 days alone until my son called the police to do a welfare check. I spent 3 days in the ICU and a total of a week in the hospital with severe sepsis, shock, and pneumonia. I was tested negative for COVID. I've been since diagnosed with hypothyroidism, high blood pressure, and anemia, and I'm having severe hair loss, depression, muscle aches, and fatigue. I'm beginning to believe I did have COVID even after testing negative. Is this possible? And my follow-up question is, does it matter anymore?
Yes, it still matters, because, you know, in that case, I think what we really need to advocate for is this, you know, once again, this idea that just because you received a negative PCR test doesn't mean you didn't have COVID, and therefore we need to document these cases. We need to write petitions. We need to focus
Right.
on the idea of presumptive positive diagnoses based on symptoms. The story that you just told is quite common to me because many of my internist friends tell the same story. Many people who came in with a negative COVID test, then went on a ventilator, then had all of the blood work associated with a case of COVID. And then, you know, right at the end of it, we're told, okay, you didn't have COVID, you just had a pneumonia or something. Now,
Right.
they're
being undercounted from a policy perspective.
Yeah, and we're in a very tenuous situation. This is a situation that we've argued and had conversations with the World Health Organization on this as well, and I understand where they are as well, because there are a number of world leaders who do not want the idea of a presumptive positive, you know, diagnosis based on symptoms.
Because then it will to people being able to go out on disability based on a clinical diagnosis as opposed to a PCR or antibody.
Well, it'll make the numbers look bad.
Sure.
And so the organizations like the CDC and the World Health Organization are concerned about being taken seriously if they start saying, you know, they need to play a very tenuous game of, if we get discredited, we can do less to help the community than if we stay very strict and adhere to very strict agreed upon guidelines. You know, we don't have anyone in the US government denying that a positive PCR test means that you had COVID, that we just have people in the US government saying you shouldn't get tested because tests make the numbers look bad. So at the very least, you know, organizations like the CDC and the WHO are saying, well, let's stick to those guidelines, but let's be extremely strict so that no one can look back and say you were doctoring the books and making this look worse than it was. Now, of course, the flip side to that is that there could be many people who are getting their symptoms ignored or denied, and strongly get the message out. And this is, you know, one of the things that our group has been advocating for nonstop, tirelessly, that to certain research programs that study certain things, but access to care for COVID should not be gated by a positive or negative PCR test. You should not get to say you don't get care because of what your antibodies look like or your PCR looks like. That's nonsense, and no one should stand for it.
Well, you have 91,000 people right here agreeing with you. I'm going to just go through, I know we're running out of time, so I'm going to just ask you a couple of quick questions to end with. Someone asked this, I thought this was interesting. You sort of started to refer to it before, but are long haulers experiencing a cytokine storm in slow motion? And if so, can you stop the process? Is that possible?
So
if you can just define the term for those people who might not be familiar with it.
Yes. So
the cytokine storm.
Once again, cytokines are just molecules that run through that infection, and they help your immune system to sort of mount a defense. However, what happens with with COVID, what is a well-documented thing is that you have this phenomenon known as cytokine storm, where the immune response with your cytokines is so strong that all of your cytokines are released and they can start to do toxic things to your body. And they can cause inflammation, and they can cause what has been called hypercoagulability, which means lots of clots forming everywhere.
Right.
And one of our theories is that one of our theories is that long haulers may be individuals that experienced a very strong cytokine storm during their infection, because interestingly, cytokine storm can be, it can accompany COVID infection that is very mild or very severe. It isn't correlated with the severity of your external symptoms. So
that's so interesting, because I've only heard it in reference to people who are in the ICU, yet we're seeing that the long haulers are the ones who generally recovered at home.
yes,
So
so
I didn't realize that could happen.
Often you only really hear about it in the ICU because that's where they're testing cytokine levels. So they can cytokine levels, to get it tested by like LabQuest or something like that, is like outrageously expensive. And so that's why we're really excited about the study that we want to initiate with the team at Yale, because they're offering to cover the cost of cytokine testing on all of the long haulers that we bring in. So that was incredibly generous of the professor that reached out, and we're working.
Thank you. Yeah.
Yeah, absolutely. And and this is how good work happens, by teamwork.
Yeah.
So that is something that we want to actively look into, is what is happening to cytokine levels in long haulers. This particular individual who's working with us, she also actually recently published a paper showing that that actually might draw a link between cytokine levels and the gender differences that we're seeing in long haulers, because at our current...
You know what? So I'm so curious about that. Okay, because so obviously, so more women tend to post on social media than men. So we have a skewed representation. What are you seeing? Because presumably you're seeing a more representative demographic. Are women actually, or is it just our group?
Roughly 70% women. Now, let's be clear, that may be because many of the people who are hearing about us are hearing about it from advocacy groups such as yours. But
Sure.
I do think that that there is, I think that the skew is real. And one of the papers that I just read about cytokine storm and severity of symptoms is that in acute COVID, so this has not been done in chronic COVID yet, but in acute COVID, cytokine storm predicted worse symptoms and longer lasting symptoms in women, not men. And so this instinct that it could be related to cytokines is something that I really want to look into. I think it's important that we look into, because I think it's an important piece of the story.
That's fascinating. So on that note, I know that we need to wrap up. I'm going to put in a pitch for all of you watching to participate in our next study that's going to be going up, hopefully by the end of this week. If not, it will be up at the beginning of next week. If you have seen the news media being driven for the last 2 weeks by our last study, that's because you participated in a poll. And our next study is going to be looking at trying to figure out what is the profile of the person who becomes a long hauler, and what are the gender differences? What medicines were you on? What were pre-existing conditions? There's so many questions that we need to find the answers to and work collaboratively with the medical community, but we need you to participate in all of these studies, and please fill out every poll that that Survivor Corps puts up, and visit us at survivorcorps.com to find out how you can donate plasma, how you can participate in medical trials and studies. And with that, I'm going to ask you the last question of the day, Dr. Putrino, because I can't end anything without talking about donating plasma. You have to be 14 days symptom-free. What does that mean if you still get an occasional headache or you still have an occasional cough? I know that smell and taste is not considered a symptom for that, but we haven't been able to get any guidance other than no fever. We know that people are having shortness of breath for months afterwards. Should they be waiting until they are fully better? Is it going to compromise their health at all to donate? What's your best advice?
Absolutely. Best advice is following, I get to just really follow my hospital's plasma donation guidelines, which is absolutely no symptoms. So no occasional cough. No shortness of breath, nothing that you did not have before your COVID infection.
Okay, other than the smell and taste, which I have been told was a carve out by the FDA.
That is correct. Loss of sense of smell and loss of taste are acceptable so long as all other symptoms have been absent for 2 weeks.
The best part of these webinars is that now so many of our questions are answered, and when people post these questions, I can just go on and say the answer we have been told by Dr. Putrino is X, Y, or Z. So thank you so much. We have enough questions to ask you for another several hours, but you have important work to do, and we are so appreciative of the time that you have spent with us for the second time, and I hope that there will be a third. We thank you so much for everything that you are doing for this community and for the world.
No
We're
worries.
so appreciative.
Thank you for having me, and there'll definitely be a third if you'll have me.